Alright, so now hematology, anatomy. The embryology section and the anatomy section are both pretty small. There's not dense amounts of information in either of them. In embryology, we saw where red blood cells are made, and we talked a little bit about hemolytic disease in the newborn. In anatomy, we finally get to see how the multipotent stem cell finally gives rise to everything that we have. And then later on, we're basically going to see pathology that is related to each one of these different cells, right? So all blood cells are made via hematopoiesis. They all derive from the same multipotent stem cell. So stem cells can differentiate into multiple cell lines, but not other tissues. These are called hematopoietic stem cells, which first divide to replace themselves before differentiating. Then you have the myeloid and lymphoid cells. So these two guys, right? Now, the myeloid stem cell gives you your red blood cells, your platelets, your granulocytes, right? Eosinophil, basophil, neutrophil, they have granules on them, and your monocytes, which ultimately give you the macrophage. Your lymphoid stem cell for lymph, so you get your B, T, and natural killer cells, right? Now, there was this word normoblast, which actually came from an NBME question that I was looking at. A normoblast is an immature red blood cell containing hemoglobin and pycnotic nucleus and normally presents in bone marrow but appearing in the blood in many anemias. Compare erythroblast. All right. So generally speaking, normoblast was just a weird word. When I first saw it, I really couldn't figure out what it might be because, of course, having the blast in the name means it's immature. But I still couldn't figure out what it could be because it's obviously not in the book. I've never really seen it in Kaplan or any other place, so that's what a normoblast is. And there's a bunch of other words, but NBME loves using these weird words that you would never hear before, anywhere else. Also, this visualization that they're showing you here is pretty much the histological visualization of all of these guys. So the most important thing is to know the histological visualization of these guys right here, right? Eosinophils are acidophilic, and acidic things usually stain pink. So that's what this is, right? So they have they're acidophilic because they have these pink granules on them. Basophils are basic, so that's an easy way to remember that, right? And they stain a dark blue, purple kind of way. Neutrophils are pretty much neutral, so they don't really have many granules that are going to stain. But the most distinguishing factor about neutrophils is that they have multiple lobules in the nucleus, right? Multiloculated nuclei. And keep in mind band cells, right? If you see a high number of band cells in any patient, in any peripheral smear, you see a lot of band cells. Band cells are immature neutrophils. That means that this patient is making a lot of neutrophils, right? And everyone starts off by first making band cells, then they become neutrophils. The other unique thing about neutrophils is that if a neutrophil has too many lobules to it, 6 or more, 5 or more, like even this actually looks like too many. It's usually supposed to be 3, right? 3 or 4. If it has 5 or more, then you want to start thinking of some kind of deficiency in a certain vitamin, and we're going to get to that. But to tell you, it's basically B12 deficiency, right? When you have a patient with B12 deficiency, they start having multilobulated neutrophils. Other than that, there really isn't much else to take from here. Just make sure you understand that this is the basic classification of all these cells, and it's not something new. We've been seeing this since the beginning of med school, so it's really important that you make sure you do know it. The rest of this really just delves into each one of them and tells you more about it. So first things first, neutrophil, right? Neutrophils are part of the innate immune system from immunology. So I've always told you guys when is a good time to go back and review something, right? After we finish Hem-Onc anatomy right now, after this video, would be an excellent time to go back to immunology and review that, right? Review the different parts of your immune system and how your immune system reacts to different things, and review the interleukins once again. So neutrophils are part of the innate immune system, which means you're born with it. Acute inflammatory response cells. Numbers increase during bacterial infections. They are phagocytic, so they can eat the bacteria. They also have multi-lobed nuclei. Usually it's going to be, so it's one nucleus. Make sure you know that too. It is one nucleus with multiple lobules to it, right? Do not pick multinucleated. It has multiple lobules to it. So that's why I'm saying multilobulated, right? Many lobes. But it's one nucleus. So multiple lobes in one nucleus is basically a neutrophil. Specific granules. Now, this is the hardest stuff to memorize, but you have to memorize it. Specific granules contain the leukocyte alkaline phosphatase, collagenase, lysozyme, and lactoferrin, all of which are really important for fighting bacteria. The azurophilic granules that they have are basically the lysosomes. So the azurophilic granules have proteinases, acid phosphatase, myeloperoxidase, and beta-glucuronidase, which are also pretty important for fighting other bacteria. There is no easy way to memorize what each of the two different granules has, so you have to do whatever you can to memorize it, right? I mean, for me, it was generally just repeatedly looking at it. You can memorize everything that's in the specific one, and then you obviously know whatever else is mentioned is not in these specifics, so it must be in the azurophilic, all right? So go ahead and do whatever you think is best. It was pretty difficult for me. I just went with the fact that everything that starts with an L pretty much is in the specific granule, right? So leukocyte, alkaline phosphatase, lysozyme, lactoferrin, those are all guys that are in the specific granule. A xerophilic one has the proteinase, acid phosphatase, myeloperoxidase, right? All the guys with the P in it. Right? So L and P was basically my breakdown thing for the two, but it was kind of weird, you know. And I also went with AB, right? So xerophilic, beta-glucuronidase. And that was really all. So you got to make up like something like that that'll help you remember what's in each one of those different granules. You can easily get a question on it. Hypersegmented neutrophils, which have 6 or more lobes. Even 5 lobes are, though, definitely a thing. Right? But let's say 6 or more, because 6 or more is like the cutoff point they're picking so you don't mess up. 6 or more lobes, that's going to be seen in vitamin B12 or folate deficiency, both of which basically cause macrocytic anemia, right? Hypersegmented neutrophils are most likely going to be a question about B12 deficiency, but it can be seen in folate deficiency too, right? This specific image here is actually really, really interesting because what you're seeing a lot of things in here, right? You're also seeing these cells that have the weird spikiness to the red blood cell, right? And then you're also seeing something that looks like a rouleau formation, like there's inflammation causing the red blood cells to kind of stick to each other. So it's a really interesting picture, but the main goal in this picture was to notice that you could see this neutrophil has more than 6 lobules to it, all right? On the left over here, we're looking at different things. So this one here is a band cell, right? This is a band cell, and then on the left we have a more mature neutrophil, but these are all normal neutrophils. So a band cell is a normal thing too, it's just immature. A left shift with increased band cells means you have immature neutrophils. It reflects a state of increased myeloid proliferation. Calling it a left shift basically means going back in the timeline, right? So like if this image here was, instead of from up down, if it was made from left to right, then you would have a myeloid stem cell becomes a band cell, which becomes a neutrophil. A left shift would mean going back to the band cell, right? So if you have more band cells than you have neutrophils, or if you have more band cells than you normally would have, that's a sign of someone with increased infection, and they're making neutrophils. But in the clinical scenario, it reflects a state of increased myeloid proliferation, which, you know, of course it could happen in bacterial infections, and if the patient has a bacterial infection, you'll probably see symptoms. But the scarier thing is the CML, right? You have to watch out for that. When you do Hem and Oncology in the hospital, every time you see high levels of eosinophils or high levels of any white blood cell that normally shouldn't be at that height, you start thinking you have cancers, right? And you have to knock out that ruling. You have to make sure you can take that differential out of the question, because you don't want to risk having possibly caught a cancer and then ignoring it. Important neutrophil chemotactic factors, all of which we saw in immunology, are your C5a, interleukin 8, right? Clean up at IL-8, leukotriene B4 because neutrophils come before everybody else, kallikrein, and platelet activating factor. All of these guys are guys that make neutrophils come to a site of infection. All right. Also keep in mind who would have which kind of deficiency. So a patient practicing veganism may have a lack of B12 because B12 is found in meats and stuff, and that can give hypersegmented neutrophils along with the macrocytic anemia. Alcoholism causes depletion of B9 because B9 is stored in the liver, and so is B12, but not so much of it. And the main difference between B12 and B9 deficiency was that B12 is necessary also for making myelin. So you start seeing nervous system defects in B12 deficiency, whereas you would have no kind of peripheral neuropathy or anything like that in B9 deficiency. This is another thing I made up when I was trying to recently teach this to people. So for my own test, to memorize specific granules, I already told you, I used that everything with the L is in specific granules, and eosinophilic ones, everything that has a P in it. This thing right here is another thing I use to teach it to people. So I wrote a big PIMP is for the azure granules, have beta-glucuronidase, proteinase, myeloperoxidase, and phosphatase, right? The I doesn't stand for anything. Whereas the specific cell, right, specific granules have collagenase and then LLL, right? So all that stuff. Whatever you want to use. I just keep making up things. You never know what's going to help your different students, so you go ahead and use it. This is a question from USMLE RX. This one says, the CBC, complete blood cell count of a patient, demonstrates an anemia with a low reticulocyte count and thrombocytopenia. Where is the most likely location of the pathologic process in this patient? So if you have a low reticulocyte count, the reticulocyte is immature. This is the first thing you make to make red blood cells. Reticulocytes become red blood cells. Right, you can see that here. Reticulocytes become erythrocytes. So your bone marrow makes that. And then they also tell you that you also have thrombocytopenia, which means you're not making thrombocytes, right? And thrombocytes basically come from the megakaryocyte, which is also from the bone marrow. So this must be the bone marrow issue, right? A patient with no thrombocytes, no reticulocytes, your bone marrow is not working. So it's most likely at or before the common myeloid progenitor cell, because both platelets and red blood cells are low, and the low reticulocyte count tells that the red blood cells are not being replenished. All right, so the bone marrow is where you have your problem. It's really important to be able to understand where the problem is. It's almost never the tissue, but the problem is either going to be in one of these levels right here at the blood level, or something in the bone marrow. And if it's something in the bone marrow, it's usually just going to lead to anemia and loss of platelets. Later on, we're also going to see a difference between what do loss of platelets do versus what do loss of coagulation factors do. There's a very big difference between the two. If you don't have platelets, you can't stop bleeding and you start getting thrombocytopenia, which basically defines to not having platelets, and you note purpura in patients. You're going to see all these little red dots all over the body, purpura and petechiae. With loss of coagulation factors, that leads to bleeding, like actual bleeding and big amounts of bleeding from small cuts and stuff, and they can't stop it. All right, so we're going to look more into that when we get there. The next cell they talk about are erythrocytes. All right, so as I said, it's always important to look up more pictures of things, because you might get something that's a completely different color with completely different visualization because of the stain they're using, and you have to know what's being visualized in that stain. So erythrocytes, we know they carry oxygen to tissues and they carry back CO2 to the lungs. They are anucleate because they don't really need that nucleus, and they lack organelles. They don't need the nucleus because it would take up too much space, and red blood cells don't really carry out any kind of function. They're just carriers. Red blood cells don't have a true function to them. They just carry things. They carry oxygen and they carry back CO2. On top of that, they also lack other organelles, so that goes back to biochemistry, reminding you that erythrocytes cannot use ketone bodies. They don't have any organelles, all right? Which means, again, we're talking about mitochondria as well. So red blood cells really just work with sugar. Sugar is a must for red blood cells. They have to have that. Because of all this emptiness, though, they're also able to have this biconcave shape, right? Since everything's empty in the middle, they can have this weird shape that allows them to kind of just squeeze into almost anywhere. And it increases their surface area to volume ratio, allowing them to really quickly pick up oxygen. Lifespan of 120 days. Source of energy is glucose, 90% used in glycolysis and 10% via the HMP shunt. Membranes contain a chloride bicarbonate antiporter, which is really important. Right, a chloride bicarbonate antiporter. So taking in chloride, taking out bicarbonate. We're going to see this a lot in action when we look at the Bohr effect and stuff like that. These are the things that let it carry CO2 and bring back bicarbonate stuff. Right, so they tell you this chloride bicarbonate antiporter allows red blood cells to export bicarbonate and transport CO2 from the periphery, like muscles and stuff, to the lung for elimination. And then on the right side, they basically tell you a bunch of terms, right? So erythrocytosis, basically you're making a lot of erythrocytes, so that's polycythemia. You would see that in polycythemia, and you're going to have a high hematocrit. Anisocytosis is any size, is how I look at it. So you have varying sizes, any size. Poikilocytosis is varying shapes, so poikilo and shape both have a P in it. And if you combine the words, anisopoikilocytosis, that's varying size and shapes. A reticulocyte is you having immature red blood cells. So just like looking at band cells tells you you're making neutrophils, if you see a lot of reticulocytes, it means you're making a lot of red blood cells. Bluish color, or polychromasia, on the right GM sustainer reticulocytes represents the residual ribosomal RNA. Right? They don't have nucleus, they don't have a DNA, they don't have anything. So this image here is showing you that. Right? So if you ever get a question, and I'm pretty sure, I remember this, yeah, UWorld had a question on ribosomal RNA, which we talked about in biochemistry. So if you take red blood cells and you stain them with right GM stain, right, you can see the bluish colors that are being tagged on some of them. That is ribosomal RNA, residual ribosomal RNA, right? Right GM stain, or even methylene blue, right? Super vital stain called methylene blue. This helps us detect how young a red blood cell is because it still has residual RNA in it, residual rRNA in it. A large amount of reticulocytes means you are making blood to replace what was lost. If you are not making new reticulocytes, there may be a bone marrow malfunction. And then hemoglobin A1C is indicative of the past 120 days because it takes 120 days. All red blood cells live for about 3 months, and then you make new ones. Let me see. Yeah, 120 days, they tell you that. Okay. Next thing, thrombocytes. So thrombocytes are what give you platelets. These guys are involved in what's known as primary hemostasis, which basically means they're the first guys to try to stop you from bleeding. Small cytoplasmic fragments derived from megakaryocytes, and these guys have a lifespan of about 8 to 10 days. When activated by endothelial injury, they aggregate with other platelets and interact with fibrinogen to form platelet plugs, and we're going to have to know that interaction as we go on. Later on, we're going to see how that interaction works and what receptors are necessary to use fibrinogen to make platelets connect and try to make a platelet plug. These guys also have granules, just like we saw earlier with neutrophils. So thrombocytes have dense granules and alpha granules. The dense granules have ADP and calcium. All right? The alpha granules have things that don't really have an A to it. So you have von Willebrand factor, fibrinogen, fibronectin, and factor 4. Right? All these Fs. Everything with an F is in an alpha granule. So you can always think of that. Right? This is a really nice way to memorize it. Alpha granule with an F. All of these things have an F in it. The dense granules have the ADP and calcium, which do not have an F in it. So it's pretty easy to memorize, and you really have to test yourself on it, either with flashcards or just thinking about it in your mind later on, which is my favorite way of thinking about it. So if I needed to make sure I know this, later on when I may be doing lunch or something, I'll tell myself, all right, what were the things in the platelets? And I'll try to remember, all right, dense granules, ADP and calcium, alpha granules were all the F things like factor 4, fibrinogen, and so on, all right? And as long as you can remember even that much, it's good enough, because then you'll see answer choices and it'll really help you. Approximately 1/3 of the platelet pool is stored in the spleen. So when a person doesn't have a spleen, they're going to have more platelets actually floating around in their blood. Make sure you understand that. Right? So a patient who either got a splenectomy or autosplenectomy because of sickle cell, or they had an injury to their spleen from some kind of trauma, anyone who loses their spleen will have more platelets floating around in their blood. It doesn't mean they have cancer, right? It just means they don't have a spleen to store it all, so it's just floating around. Thrombocytopenia, or a decrease in platelet function, results in petechiae, right? So if your question is not telling you about petechiae, the patient does not have petechiae, then you do not have a platelet problem. Then it's probably a coagulation factor problem. And this is a really big differential that you need to really be able to understand, right? There's no overlap. There are very few diseases that cause both loss of platelets and loss of coagulation factors. And when we see the pathologies, we'll talk about that. Then, of course, later on, when we get to physiology, we'll see these receptors and how they work. So von Willebrand factor, its receptor is GP1B. GP2B3A is the receptor for fibrinogen. There's no easy way to memorize this. This is something you memorize by doing more and more questions and repetitive exposure. Right? The more times you look at it, the more it sticks to you. And we're going to see a lot of that when we get to physiology. Thrombopoietin is a medication that stimulates megakaryocyte proliferation to help you make more thrombocytes, and you can have more platelets if you need it. And that's generally all there is over here. Keep in mind, though, lifespan 8 to 10 days. So a patient on aspirin requires 10 days to recover platelet function, so you must wait before performing any surgery. Note that 1/3 of total platelets are in the spleen, so patients with splenomegaly may be thrombocytopenic. Oh, this is the other case scenario. I told you guys that if a person loses their spleen, they're going to have a lot of platelets floating around in their blood, and that's okay. If you have splenomegaly because of some kind of infection or whatever, that means that all your platelets must be in your spleen. Of course, other things are in there too, but a lot more. Not just 1/3 of platelets, but much more is in the spleen now. So you could look like you're thrombocytopenic, but in reality, you're not. Right? So I put the other thing too. And patients with no spleen will have an elevated platelet count, since that 1/3 that was supposed to be in the platelet pool in the spleen is now circulating. So really pay attention to that if you see a question about a patient and whether or not they have their own spleen. For the other guys, I found these cool 3D images, so I put them in too, and we'll take a look at that. So monocytes. Monocytes are basically going to give you your macrophages, and they're found in blood. They differentiate into macrophages in the tissue, not in the blood, and they're large, and they have what's always called a kidney-shaped nucleus, right? Extensive frosted glass cytoplasm. Frosted glass, I don't know why they came up with this frosted glass thing. I mean, it's kind of weird to call it that, but basically the cytoplasm area doesn't really have any granules, right? You can see there's no granules. In this 3D version of the image, you can get a better appreciation for what does look like ice, right? Frosted glass with a big kidney bean in there. But we don't care about that. We're never really going to be looking at 3D images. We're going to be looking at histological images, and you need to understand that this is pretty similar to many other things, right? Even later on when monocytes become macrophages, like there's a good overlap. They look pretty similar still. So main thing is there's no granules. There's no granules on the outside. So the cytoplasm is pretty clear. All right, mono is one nucleus and the site is just a cell. So monocytes become macrophages, and now we're looking at macrophages right here. These guys, phagocytose bacteria, any cellular debris from maybe you had an MI, maybe you had some cells that died, maybe you got a bruise. And they also eat dead red blood cells. We saw that in GIT. Macrophages are the guy that eat the dead red blood cells and then recycle heme, and they also make insoluble, indirect bilirubin, right? Thanks to macrophages. Long life in tissues, and they differentiate from circulating blood monocytes. They're activated by gamma interferon, which is another immunology thing. So we saw that when we were in immunology. Gamma interferon's job was to activate macrophages. There's many other interferons, but the gamma one is the one that does this. Can also function as an antigen-presenting cell via MAC2, right? And MAC2, from immunology, we learned that the numbers have to add up. So MAC2 works with CD4. CD4 is positive T cells, all right? Important cellular component of granulomas. So TB, sarcoidosis, any of these things. Anytime you see a patient that has a granuloma, we've seen this already from endocrine as well as in GIT. The main thing you need to remember about a granuloma is that if you have a granuloma, you have a lot of macrophages. And if you have a lot of macrophages, you're also going to have this weird thing that happens that leads to more vitamin D. Right? So you have a lot of vitamin D, so you can actually get more calcium, better bones and stuff like that. Something like that does happen, and we're going to talk about that later on. But just keep that in mind. Granulomas, macrophages, and macrophages, vitamin D. Name differs in each tissue type, and you need to know that because they love testing you on the names. So in the liver, as we saw in GIT, the macrophage is known as a Kupffer cell. Right? A Kupffer cell is the macrophage of your liver. The Langerhans cells are the macrophage in the skin. Osteoclasts are basically the macrophage of your bone, and osteoclasts make bone. And microglial cells, all your microglia, are basically the macrophage of your brain. Lipid A, which is something we saw in microbiology, lipid A from bacterial lipopolysaccharide binds CD14 on macrophages, and this is how you initiate septic shock. Right, so a lot of immunology is being discussed already, and this is why it's really important that after we finish talking about hem-onc anatomy right now, you go back to immunology and make sure you understand and refresh the fact that gamma interferon activates macrophages, and CD14 is the target for lipid A, leading to septic shock. Alright, so that's, and then down here I wrote, so MAC2, right? MAC2 from immunology is for the adaptive immune response, which means you're not born with it. Macrophages also work as part of the innate immune response, which macrophages you are born with it, but this MAC2 thing, of working as an antigen-presenting cell. This is something you learn over time. Macrophages and TNF-alpha are the main actors in any granulomatous diseases involving gamma interferon. So make sure that you do go back to immunology and really get that stuff down, because you get questions on these things and all the answer choices are going to look very similar if you're not very sure about what's happening. Alright, then we have our granulated guys, right? All the things that have granules on it. Eosinophils, as we said, are acidic, so acidic things are always going to be pink, and that's what we see here, right? Pink granules on the whole cell. These guys defend against helminthic infections because they have something called major basic protein, and that's very high yield. You get a lot of questions about major basic protein. And anytime you get a question about eosinophils, there's something weird that's going to happen. We're going to see that eosinophils are related to asthma, but so are other guys. Right? Mast cells are related to asthma. We're also going to see something about asthma with basophils. So at some point, it becomes a little hard to figure out what cell are we talking about when a patient has asthma, right? It could be all of them. It could be one specific guy. It really depends on what caused it. But mainly, when you think of an eosinophil, you really want to think of parasites, right? The helminthic infection. Also, it's got two lobes, as you can see, right? It's bilobate. In this 3D version, you can see it even better. Two lobes, but it is one nucleus, right? It's not multiple nuclei. One nucleus with pink granules on it. Packed with large eosinophilic granules of uniform size, highly phagocytic for antigen-antibody complexes. So it also cleans up any of your antigen-antibody complexes. What does it make? Other than major basic protein, it makes histaminase. It can make eosinophil peroxidase, eosinophil cationic protein, and eosinophil-derived neurotoxin. All of which are probably things you've never really talked much about. Like the most commonly talked about are histaminase and major basic protein. So at the top I wrote a little more about the others. Eosinophil cationic protein is also known as ribonuclease 3, and that's related to inflammation and asthma. It's also closely related to eosinophil-derived neurotoxin, and both of them possess neurotoxic and helminthotoxic as well as ribonucleolytic activities. In asthma, eosinophils release histaminase and aryl sulfatase to limit the allergic reaction after mast cells degranulate. So eosin is for pink dye, philic is loving. Causes of eosinophilia are your Pac-Man guys. So anyone who has high levels of eosinophils has to have one of these things, or may have one of these things, and you want to check for that. We've talked about parasites, so parasites are always related to eosinophilia. We have not talked much about asthma, that's in respiratory. Churg-Strauss syndrome we're going to see soon enough. We talked a lot about chronic adrenal insufficiency when we did endocrine. Right? And in chronic adrenal insufficiency, you will have eosinophilia. Don't forget that. You can actually get an endocrine question about chronic adrenal insufficiency, and then they can ask you what cell type would be elevated. You have to pick eosinophils. You also see this in myeloproliferative disorders and Hodgkin lymphoma, as well as many other cancers. So that's why if you ever see a high number of eosinophils in one of your patient's lab reports, you should forward that to an oncologist, have them take a look, and then really see if there's any evaluation that's necessary. Right? And then, of course, the allergic process. So that's your eosinophil. It's probably the most important of the guys that have a granule on it, and it's most likely the answer. If you have a weird question that you're not too sure about what to pick, just go with the eosinophil. Basophils and mast cells are very specific things. They do things that are very clear, and you shouldn't be too confused about picking them. Basophils are basic, so they stain blue, right? So all of that is BBB. It's all going to be blue colors. You can't forget that. Don't make a confusion. Eosinophil starts with an E, and it's pink, and it's acidic. Basophils are basic and blue. They mediate the allergic reaction, right? And that's really weird, because you keep seeing allergy, right? You keep seeing allergy, you're going to keep seeing asthma, and it's really hard to figure that out. In fact, basophil allergic reaction, eosinophil allergic process, and then in mast cells, you see, again, allergic reaction. So it's really important to know which one of these guys is the correct answer based off of different questions regarding allergy. We didn't really see too much about allergic stuff here, right? Besides the histaminase, basophils are the ones that actually mediate the allergic reaction. They have densely basophilic granules that contain heparin, which is an anticoagulant you know about, and histamine, which is a vasodilator. Leukotrienes are synthesized and released on demand. Right? Basophilia is very uncommon. You should not have high amounts of basophils. But if you do, if you have a very high amount of basophils as compared to normal, then you really want to start considering CML, right? Or any kind of leukemia, myeloproliferative disorder, whatever it might be, because it's very, very rare to see high numbers of basophils. Last one here is your mast cell, right? In terms of guys that can have anything to do with allergic reaction. Your mast cell, as you can see from these two pictures, looks very similar to the basophil, right? So it's not easy on histology to differentiate. Oftentimes what you have to do on histology is compare to the red blood cell that will be next to them. But even in these pictures, you could tell that the red blood cells and this also look like they have the same ratio as basophils in this. Right? Mast cells mediate the local tissue allergic reaction. Contains basophilic granules, just like basophils, originate from the same precursor as basophils but are not the same cell type, can bind the Fc portion of IgE to membrane. So it basically helps your IgE connect to the membrane. And mast cells are activated by tissue trauma, C3 or C5a, and surface IgE cross-linking by antigen. All of that would lead to degranulation. Any one of those things would lead to degranulation of the mast cell, which releases histamine, heparin, tryptase, and eosinophil chemotactic factor, right? Making this guy look very similar to both basophils and eosinophils. It looks like a basophil, and it has activity like eosinophil chemotactic factor. It has some activity that makes it look like an eosinophil. Most importantly, because this thing is for local tissue allergic reaction, you want to make sure you pick mast cell if it's about something like a nickel allergy or something weird like that. And it's really directly related to type 1 hypersensitivity reactions. Remember in immunology we talked about the different type of hypersensitivity reactions, and type 1 had one thing, an antigen. No antibodies, right? Type 2 had antigen and antibody, and type 3 had antigen, antibody, and complement, all of which made it complex. Type 4 had none of those things. It doesn't have antigen, doesn't have antibody, it's none of that. It's just a delayed reaction. Cromolyn sodium is actually a medication that prevents mast cell degranulation, and you could use this for asthma prophylaxis, right? And again, another confusing thing, right? We're talking about asthma. We said that asthma is related to eosinophils. However, the medication for asthma is over here for mast cells. Right, so don't get thrown off by that too much. You really should be able to pick the right cell based off of what other information is given in the question. Vancomycin, opioids, and radiocontrast dye can elicit an IgE-independent mast cell degranulation, which is really cool. So if you get a question about someone having mast cell degranulation and there's no IgE involved, right? If there's no IgE involved, then you think of vanco, opioids, and radiocontrast. Alright, let's take a look at what this little note right here says. So I wrote, when an allergen is in the body, IgE will bind to the allergen and the binding sites, and the mast cell will bind the IgE at the Fc portion. When enough allergen is present to make IgE cluster and cross-link the receptors, the cells will degranulate, releasing histamine, heparin, and eosinophil chemotactic factors. That is your type 1 hypersensitivity reaction. Related to allergic reactions, asthma, hay fever, allergic rhinitis, and whatever else they talked about in immunology when they mentioned type 1 hypersensitivity. Alright, so that's all of them. The last thing on this page itself is a dendritic cell. Right, so this is an electron microscopy image showing you the same thing, a dendritic cell. So a highly phagocytic antigen presenting cell functions as a link between the innate and adaptive immune system. It expresses MAC2 and Fc receptors on the surface. Dendritic cells derive from the monocyte, and they're the main inducers of primary humoral immunity from immunology. So that primary humoral immunity is your B cells and T cells. Macrophages and B cells are antigen-presenting cells too, but the dendritic cells are the best antigen-presenting cells. Right? They're the main ones. And this here is basically a combination image showing you multiple guys. Right? So this one over here is most notably a neutrophil. There's no granules. You have multiple lobules to it. The one on the top right is mainly covered by the nucleus. Right? The majority of the cytoplasm is filled with a nucleus. That is a lymphocyte. And this here, this is your kidney shape with what they called a frosted glass nucleus, right? They called it a very frosted looking kind of weird name. That's your monocyte, right? So you should practice a couple images like this on the internet where you could find histological images of red blood cells or any other white blood cell, and you can see how they all look like. Comparing to the size of red blood cells that are around is always something that's really important. This question from USMLE RX also makes a pretty good point. So this one says, a 6-year-old child is brought to the pediatrician after multiple bouts of wheezing and breathlessness on the playground. A diagnosis of asthma is made, and follow-up complete blood count identifies a higher than normal percentage of granule-rich cells in the patient's blood. What is the major granular component found in this cell type? So you're finding a higher than normal granule-rich cell, and the only granule-rich cell that we said can be higher is your eosinophil, right? Because basophilia, having a lot of basophils, would be cancer. And eosinophils have the major basic protein, right? So this child has asthma, which is the A in Pac-Man of eosinophils. 2 cells are involved in the pathogenesis of asthma: mast cells and eosinophils. Eosinophils are mainly known for their major basic protein. Heparin, answer choice A, is a component of basophils and mast cells, as well as anticoagulant in type 1 hypersensitivity, allergic degranulation. Histamine is also released by basophils and mast cells and is a vasodilator in allergic degranulation. Myeloperoxidase is used by neutrophils to kill bacteria, while IgE is made by plasma cells. Right? And we also saw IgE right here is necessary for mast cells to be degranulating, to activate mast cells. So even if you didn't know what the answer was, you could knock out other answer choices by knowing everything about them. And that's a really important tool to use on your actual step 1. This last page goes into your lymphoid progenitors, right? So again, now we're seeing the lymphocyte that we just practiced over here. So your lymphocyte is mainly going to be all nucleus when you look at a cell, right? And that's really helpful because it's very evident when you see a lymphocyte, you'll know it's a lymphocyte. So you can see, right, very high nucleus to cytoplasm ratio, practically 1-to-1. The majority of the cell is the nucleus. Lymphocytes refers to B cells, T cells, and natural killer cells, and by looking at this image, you can't figure out if this is a B cell, T cell, or natural killer cell. That you can never do just based off of you can't figure out if it's a B or T cell or natural killer cell just off of a lymphocyte. Just off of a histological image. The Pac-Man mnemonic is actually given by the book itself. All of these guys: parasites, asthma, Churg-Strauss syndrome, chronic adrenal insufficiency, myeloproliferative disorders, allergic processes, and any kind of weird neoplasia of blood cells. These are all guys that would make you make more eosinophils. And this patient in this question had the A of Pac-Man, which is the asthma. Alright, lymphocytes. So we can't tell what this is. So if you ever get a question about lymphocytes and they give you a histological image and they're like, okay, what kind of cell is it? You just pick lymphocyte. Do not pick B, T, or natural killer. You can't tell. You need to do the electron microscopy to figure that out. And I think the most common time you will get images of lymphocytes is going to have to do with Epstein-Barr virus infection or some kind of cancer, because you have to be able to identify what kind of lymphocyte it is in there. You'll see atypical lymphocytes, and you have to figure out what it is. So let me just do a quick revision of that with you guys. So if we go back to microbiology and we look at Epstein-Barr virus, let me show you what you'll see for Epstein. Yeah, this one right here. So for Epstein-Barr virus, they can give you an image like this, right? Where clearly both of these are lymphocytes, right? Super big, perfectly round nucleus. This is also a really big nucleus, but it's not round, and the cell itself looks weird. This atypical cell, they could ask you, what is this atypical cell? And at this point, you can't just pick lymphocyte. So they tell you, atypical lymphocytes on peripheral blood smear. Although Epstein-Barr virus infects B cells, this thing is a reactive cytotoxic T cell, not a B cell. This must be a reactive cytotoxic T cell. Epstein-Barr virus doesn't actually do anything to the body of a B cell. It just harbors it. It infects B cells, but it doesn't change how they look. And T cells are going to start reacting, and this is how T cells look when they react in Epstein-Barr virus. All right. Later on, we're also going to see another thing, PCNSL. That's an infection where the T cells are key, and in AIDS-related T cell lymphoma as well. So in those two guys, in any of these scenarios, it actually is an infected B cell, right? PCNSL is a, I forget what PCNSL stood for actually. Let me just look that up real quick. Because we're going to see that right here. Oh, we're going to see it in neurology, right? Primary CNS lymphoma, right? That's what PCNSL is. So when we see a primary CNS lymphoma, if they give you an image like this in primary CNS lymphoma, and they ask you what this one is, this is actually an infected B cell in primary CNS lymphoma, right? But in Epstein-Barr virus, this is a reactive T cell. And that's a very common question. They love asking you that because it's something that most people get wrong, and it's intimidating because you're just going to be very confused if you haven't done this kind of studying, or if you haven't done this video, I guess. So really important to make sure you remember that and keep that straight. Okay, so that's your lymphocyte stuff. Natural killer cells are part of the innate immune response. Round, densely staining nucleus with a small amount of pale cytoplasm. The natural killer cell is the only innate immune system cell from the lymphoid lineage, and they act very much like T cells, but without the antigen-presenting part and no MHC. It is a special function of these cells to recognize infected cells that specifically do not display MHC markers or have attached antibodies, and then cause apoptosis in them, and we've learned about that in pathology. The B and T cells cannot be differentiated by light microscopy. They are round cells with densely staining dark purple nuclei and pale minimal cytoplasm, as you can see here. Right, it is an infected B cell in primary CNS lymphoma, but it's a reactive T cell in mononucleosis from Epstein-Barr virus. Right. Natural killer cells. So that's the thing we're leading on to for lymphocytes. So we just said that this is the only guy that's an innate immune system guy in the lymphoid progenitor stuff, right? Especially against intracellular pathogens. Larger than B and T cells with distinctive cytoplasmic lytic granules containing perforin and granzymes, which we talked about in pathology. These are the guys they use to kind of just cause apoptosis and kill a cell by destroying its membrane. When released, acts on target cell to induce apoptosis. Distinguish between healthy and infected cells by identifying cell surface proteins, which you cannot do by microscopy. You have to do electron microscopy, right? Light microscopy wouldn't do it. And infected cells are going to be induced by stress, malignant transformation, or microbial infection. So natural killer cells are supposed to have CD56, and that's the one you really want to watch out for. CD16 is also important because that's the FC receptor, but they usually question you on CD56. You need the CD56 on a natural killer cell. You need both of them, but you can get questions on the 56 more likely than the 16. B cells have 19, 20, and 21, and we just saw 21 is the target for Epstein-Barr virus. 19 and 20 are found on all B cells. These guys, as well as T cells, are the guys that are going to be part of your immune response, but they do different kinds of immune response, and that difference between their immune response is something you have to review again when we go back to immunology today. So go back to immunology after we finish this video and really make sure you know everything we talked about in this video today, because otherwise you're just going to be confused and stuff. But mainly it's revision. You always need time to yourself for revision, and it's really hard to figure out, when you should go back and review certain things. So my suggestion is always to go back and review things when you're talking about it in the system. And in this system, we're talking about a lot of immunology, right? We're in Hemononc and we're talking about a lot of immunology. Go back and review the immunology principle. When we were in endocrine and GIT, we talked about a lot of metabolism and vitamins from biochemistry. So you should go back and review nutrition and metabolism while you're doing endocrine and GIT. Right? So really a very standardized way to kind of go review stuff. So B cells are part of the humoral immune response with antibodies. So these guys originate from stem cells in bone marrow and mature in marrow. Come from bone marrow and stay in the bone marrow to become mature. Very important to remember that. Migrate to peripheral lymphoid tissue, like the lymph nodes or white pulp of the spleen or unencapsulated lymphoid tissue. All of this is discussed in immunology, the first chapter of it, the first section of it. When antigen is encountered, B cells differentiate into plasma cells, which produce antibodies. They also make memory cells, so if you get an infection again, you're more prepared to fight. And B cells also work as antigen-presenting cells, but dendritic cells are the best antigen-presenting cells. T cells have CD3 and CD8, or CD3 and CD4, and we're going to learn about how this occurs. Right, later on, you do get questions on this too, on both NBME as well as your step 1. T cells mediate the cellular immune response, originate from stem cells in the bone marrow, but unlike B cells, these guys mature in the thymus. So B and T cells both come from the bone marrow, but B cells stay in the bone marrow and become mature. T cells have to go to the thymus to become mature. differentiate into cytotoxic T cells, which express CD8 and recognize MAC1, or helper T cells, which express CD4 and recognize MAC2. As well as regulatory T cells, and regulatory T cells are mostly only discussed in your immunology chapter. They don't talk more about it here. I think there was a helper 17 T cell or something. You have to go back and make sure you know that stuff too. CD28 is the co-stimulatory signal that they talk about in immunology, which really helps you. You need two signals to make T cells work, and all of those connections have to happen correctly. And I talk about it right here, I think. Helper T cells have CD4 and interact with MAC2, which are located on antisynthetinic cells. T cells need the co-stimulatory signal provided by the CD28 on T cells and the B7 on antisynthetinic cells, as well as the CD40 ligand to CD40 connection, which is really nicely discussed in immunology with visuals and everything. The last thing in anatomy is your plasma cell, which comes from the B cell itself, right? Produces large amounts of antibodies specific to a particular antigen. They call this a clock face chromatin distribution, which is really hard to see here, but basically you have you can see it's like a clock, because you have the 12, 3, 6, and 9. Right? That's what you're kind of seeing here, but it's really not that clear in this picture itself. Clock face chromatin distribution and eccentric nucleus, which means you pushed it to one corner. Abundant RER, because it has to make antibodies, and that's a protein you're going to secrete out. Well-developed Golgi apparatus, because you always need the Golgi apparatus to secrete things outside of the cell. Found in bone marrow and normally do not circulate in peripheral blood. So you should not see plasma cells in your peripheral blood. But multiple myeloma is a plasma cell dyscrasia. Right? Sometimes also described as fried egg appearance, comes from B cells, and these make antibodies. Right? The only time you see a lot of plasma cells in a person just floating around is only multiple myeloma. This is practically a plasma cell cancer. All right? So that's the end of that. In the next video, we'll dive into hematology and oncology physiology, and we'll see the intricate interplay between all of these cells that we've talked about.